Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. Saturday morning here with you early. What could be better?
You know what? I'm feeling good. Just got off a little workout. I'm very excited. This is probably the best you're gonna get me this weekend. Maybe not, but I love getting up early and getting stuff done. So this is great.
Absolutely. So you already jumped on the Peloton?
Oh yeah, it's better off if I get it done early in the morning. I feel better in the morning. I know it's done. Honestly, so I think at one of our last podcasts, we were talking about my trip to Michigan. I did a lot of running in Michigan, which was interesting and weird, but super fun. I used to run a lot, and I think I clocked over close to 60 miles in Michigan for a week, which was good for me. I
Wow.
liked being outside again.
That must have been to get you out and running. I mean, you didn't have a Peloton, obviously, but the weather must have been idyllic. Is that fair?
It was perfect. There was a Peloton at one of the places. We stayed at one hotel after like four, yeah, the Grand Hotel. Rafi's here with me. So we stayed at the Grand Hotel, one hotel at the entire trip, and they had a Peloton, but I actually opted to run instead because we were in Mackinac, and the island has a loop that's like just over 8 miles. So I clocked the loop every day I was there, which was super fun.
Yeah, it's great. I don't have to talk to you because I just look at your Instagram posts. I know exactly. I can see your run because you posted about it. I love it. Now, this is particularly painful for me because I can't run right now because of my damn knee. So I am forced to either Peloton or ride my bike to work or around, which is fine, but I miss running. I really do.
Well, you did mention to me when I ran into you in clinic the other day about hitting a PR in your Peloton. Tell me about that.
Yeah, you're gonna have to ask that again because I can't. We're getting both of you.
So I did run into you in clinic the other day, and you did mention hitting a PR on your Peloton.
Yeah, we know old people don't hit PRs as many times. Now, granted, I hadn't been riding the Peloton too long. I don't know about you and how often you try to PR or whether you're just, riding to get the ride done. I end up only competing with myself. And it's just one of those days where it looked like it was possible, and then I went for it. And it was pretty satisfying, I have to say.
Good for you. I'll be honest with you. I guess I've been riding for on the Peloton thing for over 2 years now since the pandemic started. And I don't hit PRs anymore because I was in beast mode back in the peak of the pandemic, and now I just do it for the ride. But there are, a few orthopedic surgeons on the skeleton crew that keep me honest. There's one pediatric orthopedic surgeon that I pursue pursue a lot, and she's always faster than me, and she does keep me honest.
So this is on. I've never been a part of a group on Peloton. I just do my thing. So you just made yourself part of a group, and so when you ride, if a group member happens to be on that particular ride, you compare yourselves to that person.
Or they've done it before, but yes, yes. So, but enough Peloton talk. We're going to alienate a segment of our audience. So, what's going on in your practice? You mentioned there's something changing.
So I guess I don't know if it's be careful what you wish for, but I think you realize how much I enjoy the adolescent elbow and the challenges that exist, whether that be congenital issues or post-traumatic issues. And I recognize that I am in the minority of people who enjoy it. And the reason is at least partly because the challenges of having good outcomes. But I had a brief afternoon clinic, and I wasn't that brief. It was, I don't know, I had about 25 patients, but five of the 25 were new referrals for difficult adolescent elbow issues. And it was great and it was exhausting at the same time. And it just gets me thinking about how niche this group is, this problem is, and how to better explore it. I definitely talk about these cases with a few selected people, but I'm brainstorming how to, with rare problems, coming to consensus on treatment and things like this is tricky. But I just thought it was interesting. It's the first time I've ever felt like, wow, that was a lot of adolescent elbow.
How you described your adolescent elbow is how I feel about plexus. Great, but overwhelming. I love it though, and I think that it's going to be fun to see you explore, how that niche aspect of your practice grows or doesn't grow. I'm sure it'll grow, just knowing you. But yeah, those are tough. I mean, are you going to establish some kind of case conference or, something in which you can, bring these cases to with Zoom and everything? It has made it a lot easier just to conference with people from different places.
Yeah, it was debating a case conference and putting it out there and seeing who might join. I was debating doing a webinar with one of the societies and getting a few good people and just make it case based as a starting point and kind of see what happens. I need to make sure that there are others out there that want to, grow that segment of the practice. And certainly, I'm sure there's people who want to discuss. But these things are hard to write about because there's so much variability in patient presentation. But I assume themes will present themselves over time.
Well, you heard it here first, listeners. Chuck's going to have a webinar and a case conference, and in classic Goldfarb fashion, is turning this into academic productivity like a workman, hammering nails all the time.
And as my wife says, say it out loud, and you are committed to making it happen.
We did commit you to the fitness thing, and we're closing the loop on that. So congratulations on that.
Yeah, absolutely. So, sounds like you are going to be really traveling a lot. Now, you have been traveling at least to some degree this summer, but what are your upcoming trips? Are they all work? Are they family? What's going on?
Well, we talked just to close the loop on that episode we had on national societies. So I'm finishing my travels for the Gelberman Traveling Fellowship for the Hand Society, which has been super fun. Obviously challenging because of the pandemic. The travels started in February of 2020 and are now finally concluding in September of 2022. So a much bigger spread than I think the awarders of the Gelberman Fellowship originally intended, but getting it done. I'm traveling to Brazil in a couple of weeks to see Jaime Vertelli and to talk with him about his work in plexus and nerve injury. So super excited about that. There's just a bunch of trips coming up. This is honestly my last weekend. We're recording this the last weekend of August, and this is my last weekend in town until honestly the beginning of October. Fully in town. So there's in and out, that kind of stuff. But so I'm just gonna relish this wonderful weekend.
Wow. How long are you in Brazil?
I shortened it, so it was supposed to be a total of 9 days. It's going to be 6 days, just because of the way that the travel shook out.
Mhm.
Trying not to be away as much on the weekend, so kind of shortening the trip helped me with that.
Yeah, understand. Speaking of travel, let's talk through one thing I don't want to say struggling with, but that I think is really interesting. So, I know you have recently traveled to do a grand rounds, and I've recently and will do more upcoming doing a virtual grand rounds. And it was really fun. I did it for University of Chicago, talked about wrist arthroscopy, one of my passions, and it was super fun within the confines of what can be fun on Zoom. You don't get the audience engagement. I didn't get to see people I want to see. And it did remind me how great a group the University of Chicago now has. I mean, from the attendings to in hand to the attendings in other areas. So I was excited to at least somewhat connect, but it's really interesting. I'm not a, on the one hand, it's easy and it's fun. On the other hand, as painful as travel can sometimes be, I think I would, have enjoyed it more.
I agree entirely. So we did very similar grand rounds in terms of I traveled to University of Missouri, Kansas City, so approximately a 4-hour drive, which Chicago would have been for you. I went in person, and Micah Sinclair, dear friend and a podcast listener, so hi Micah, was kind enough to invite me to do the grand rounds and gave me the option of doing it virtually. And I told her I was just going to go because it is just so much better. Everything you said is true. It is so much better to do it in person and to have those interactions. And giving a talk in front of people you've never met before, and it's kind of a blank slate is tough. It's something that I haven't done in a while. It was good to, dust off the talk and kind of get the cobwebs off and to do it. So I'm thankful that I was able to go and do it. Although the drive was a little bit long and I almost died on I-70, but it was good.
The flip side is, at 7 a.m. on Wednesday morning, I did grand rounds for an hour, and then I started operating at 8:30. So,
I hear you, man. I totally hear you. And yes, shout outs to the University of Chicago group. Megan Conti Mika and I are thick as thieves. And one of our future fellows that we matched this past May is Jason is coming from Chicago. So we're super excited. And Jeff Steppens there, Jennifer Wolf, great hand group.
Yeah, absolutely, absolutely. So, yeah, it was fun. It's interesting. I'm looking forward to traveling more. I guess I got to be careful what I wish for.
Yeah, especially you. You're gonna get looped into a lot of travel with all your responsibilities. So let's talk about some cases. I think that we should follow up on our recent cubital tunnel episode with at least some case-based discussion. Have you had any challenging cubital tunnel cases recently?
I have. I'm going to share a case from about 3 months ago that I considered sending to you, and you might roll your eyes and say you should have, or you might say I'm glad you didn't. So this patient is a 61-year-old very active male who has noticed decreasing elbow motion for the last couple of years, not painful particularly, but also kind of a stoic guy. But more concerning has been over the last 4 months, has noticed difficulty with hand function, difficulty with grip strength, and some changed appearance of his hand. And so an outside hand surgeon sent that patient to me to evaluate. And here's what I've found. And before I tell you what I did, obviously, I'd be curious as to what you would do. First of all, the patient really did have decreased elbow motion. Elbow motion was about 40 degrees shy of full extension to about 110 degrees of flexion bilaterally, not painfully except if I forced terminal extension. Patient had just a difficult to palpate elbow. Radiographs demonstrate a lot of arthritis. So it was actually hard to feel for the ulnar nerve. The ulnar nerve was irritable for certain, but was sort of almost encased. And there was atrophy in the first dorsal nerve osseous. 2-point discrimination was greater than 15 millimeters. FCU strength was good, maybe a touch decrease, but not dramatic. Dorsal ulnar hand sensation was decreased as well. So with that limited information, should I have sent the patient to you?
No, well, I would have loved to see the patient, but clearly this is your wheelhouse as well. So bilateral elbow or limited motion, but is also bilateral ulnar nerve symptoms.
No, ulnar nerve
Okay.
symptoms only on the right side. Yeah, only on the right side. I'm trying to think of how to present this further. So the patient was sent to me in part, and it was a very talented outside surgeon who said, the combination is weird. You have that bad elbow, not weird, but it's just not particularly common. Difficult elbow arthritis, notable ulnar nerve pathology with intrinsic atrophy. I'm sending the patient to you because I think perhaps there's an opportunity to deal with the elbow arthritis, transpose the nerve, and consider a nerve transfer distally all at the same time.
Yeah, so the nerve transfer thing is the thing I was thinking about once you start to say atrophy. The first thing I thought of is just to make sure it's not the neck, which is why I asked about the bilateral elbow thing. Certainly a patient of that age, I think it's appropriate to consider. So my evaluation would have included that in terms of the C-spine, just to make sure. Doesn't mean you wouldn't address the cubital tunnel, but for me, that's an important thing.
Yeah, I love that. Certainly, we clinically examine the patient, and I wish I could provide the details of the nerve study to you, but I do not recall. I know you are much more, precise regarding nerve study. To me, it just confirmed that we have a serious cubital tunnel pathology and need to address it.
Well, before I get into details of how I decide on whether to include a nerve transfer, how would you determine how you would include a nerve transfer?
Yeah, and that's why I considered sending it to you. I absolutely would have sent it to you because I know you, really engage in this type of case. The reason I didn't was because of the elbow arthritis, and while I know you're more than capable of treating that, I thought that it would make sense for me to do that, and it was a bear. So I enjoyed it.
I am very happy that you did not send this patient to me then. Because also the other thing is that if you and I tried to coordinate a surgical date, I think it would be well into December.
That is true. That is true. I guess simplistically, and you have more of an algorithmic approach, simplistically for me, a patient with a relatively acute onset of ulnar nerve symptoms with some atrophy and to me means an AIN transfer is reasonable. And I was pushed to do it honestly by the referring physician.
Got it. I think that makes sense in terms of, acute onset. I think that, full disclosure, I like doing the nerve transfer. People say that it doesn't really add any morbidity, but, that is a bigger dissection you're adding, as opposed to if you didn't do anything at the wrist or if you just did a Guillen's canal release. I think there's a lot of surgeon-driven utilization of that procedure, and I'm guilty of it too, because we feel better that we're doing something to try and address the atrophy and doing something that's going to potentially expedite the recovery. The literature is not great methodologically. I know that there are people that advocate for this, even locally here in St. Louis. Susan McKinnon is a very strong advocate of it. She developed the procedure. And I think that it is good procedure and it works well in the right population. But if you had to randomize people to ulnar nerve transposition alone versus the nerve transfer, I don't know what the outcome would be, to be honest with you. There are some very good retrospective case series demonstrating improvements objectively in the motor amplitudes on the nerve study. Particularly there are some studies from Canada that have demonstrated that are compelling, and I think really interesting for future work. For me, in terms of determining the nerve transfer, I like to see that there's a decrease in the CMAP amplitudes that is substantial, perhaps under the 30% threshold that of normal, and that there is acute denervation on the nerve study, like you mentioned. So acute denervation meaning fibrillations and sharp waves. Then looking at the recruitment pattern of the motor units. I just like to bring some objectivity to my indications for it. Because I've had a few cases even recently where the fellow or resident has asked me, why aren't we doing a nerve transfer? I say, well, look at this data. This is why. I don't think we need to. Although it is super tempting because it is a fun transfer. Technically, it's pretty straightforward. And, I think that it makes you feel like you're doing something more for the patient.
I love that. I love that. Thank you for sharing that. I mean, we've talked about that before. I don't recall if we've specifically talked about your technique, and without spending 30 minutes on it, just briefly describe, how you think about this procedure.
Happy to do it. And I also want to hear how you address the elbow arthritis component to it, because when I think about my type of transposition, I consider what is going on in terms of the elbow joint and if deeper work is done. So let's get back to that. I think that it's important to have careful indications. I use this and I use the nerve transfer in patients that have active denervation, as we just spoke about, that have a reasonable drop in their CMAP amplitudes. I do look and make sure that they've got a good median nerve and a good pronator quadratus and a good AIN. That's obvious on clinical exam, but also because they typically go for a nerve study, I have them needle the pronator quadratus. There was one case that we wrote up, that David Brogan and I wrote up, in which we had them needle the pronator quadratus, and then I went and looked for the PQ, and it was completely atrophied, which was a very not
Wow.
fun surprise to have in a case. And I learned how they needle the PQ in most places is that they actually go from dorsal. So they put the needle in dorsally, they pop through the IOM, the interosseous membrane, and then they assume that they're in the PQ. And then they check the needle characteristics when they ask the patient to pronate. So now, because of that, every time that I send somebody for a needling of the PQ or an EMG of the PQ, I have them do it on their ultrasound guidance because I don't want that surprise ever again. That's probably a harsh overreaction, but I think it is super useful. So that case report's out there. So technique-wise, I try to get everything done in 2 hours of tourniquet time. Transposition, nerve transfer, and my routine, because for that is to do the transposition, then go distally, do the nerve transfer, do the micro, close the distal wound, get it wrapped up, dressed, and then put a blue towel over it so it doesn't get messed up when we take the tourniquet down. And I like to look at my transpositions after the tourniquet's down. So then, we get all that done in 2 hours. We let the tourniquet down. I put the drain in for the transposition, and we finish up there. We're pretty good usually about getting it all done in 2 hours. Sometimes you got to run a little bit over, but to me, that's a good goal to keep the case moving along.
All right. So we have some differences, which We should take a poll, and I know what the poll would say. 80% agree
I
with
know the
Dr.
drain is
Z.
crazy. I know the drain is crazy. Okay, I know the tourniquet down is crazy.
No,
But I get it.
I,
I get it.
I love it. No, but specifically, once you, so I let me tell me what you do. You release volarly maybe half of the pronator quadratus to go more distally to where the nerve starts branching, I presume. And then tell me how you insert your AIN into your ulnar nerve.
So when we do our distal incision, sometimes I'm doing concomitant carpal tunnel release. Basically, the incision is curvilinear and the palm part, it's centered over the hook of the hamate. And then if I'm doing a concomitant carpal tunnel, I'll basically cheat the skin window radially. It's kind of like you're doing a carpal tunnel if you made your incision too ulnar. Do the carpal tunnel part, and then my skin incision across the wrist crease is in Brudner zigzag, and then it's parallel to the FCU longitudinally for approximately 6 to 8 centimeters. Sometimes a little longer, depends on the patient's anatomy. At that point, I typically try to find the ulnar nerve in the forearm, which makes it a lot easier to walk into Guillen's canal. I release Guillen's canal. I look for the ulnar artery, and there's a pretty characteristic branch of the ulnar artery that comes off at near the origin of the ADM. And that branch runs perpendicular, and that's a very good clue as to where the ulnar motor branch is coming off. There was a resident, current shoulder fellow, Ryan Hill, who worked with me, who we did a lot of these, and he was really, really good about finding that branch of the artery. And every time I was like, this is totally a clue. We talked about writing it up, but honestly, I don't think it'd get in anywhere. But that branch is a clue as to where the ulnar motor branch is going to originate. I know that everybody watches Dr. McKinnon's videos, and she talks about how, you can't really see the ulnar motor branch until you decompress it. That doesn't really jive with my personality. I like to find it before I decompress it. So I will then decompress the ulnar motor branch, the hypothenar fascia, and then I will neuralyze it back. So I don't do a complete visual neurolysis, although I know many talk about that. I do a skip neurolysis in which I will check and see. I don't love neuralizing the entire, internally neuralizing the entire motor branch off, because I think that could potentially lead to some issues. But I like to be super sure of what I'm doing. So I'll do a skip neurolysis into the forearm. There is a paper, I'm trying to remember where it's from, I think it's South Philadelphia, that demonstrates that you can use the dorsal cutaneous branch as a clue as to where to put, where your motor branch is going to be. And that typically where the dorsal cutaneous branch is coming off is where your nerve transfer is going to be inset. So that cadaver study was, I think, about 20 cadavers that showed that every time in those 20 cadavers, the ulnar motor branch was, adjacent to the dorsocutaneous branch, just like Dr. McKinnon talks about in her videos. I trust that, but I don't completely trust it, so I end up doing my skip neurolysis. After I've gotten my location for where I think I'm going to inset it, I elevate the plane between the long flexors and the PQ. I isolate my AIN. I fully acknowledge that at some point in the case, whether it's at the beginning or the end, I'm going to get into branches of the interinterosseous artery. So I usually play defense and cauterize those with the bipolar. After I've gotten a loop around my AIN, I will then address the PQ itself. I usually end up releasing 2/3 of the PQ. I usually will do that by putting a burlisher or some kind of right angle clamp or something underneath the PQ and on top of the AIN, and then releasing that initially the top layer with the Bovie on a low setting, and then eventually with the bipolar just for defense, hemostasis, that kind of thing. And the arborization of the PQ branch ends up being about halfway, and I think there is a study about that. But I will release it about 2/3. And after I think one thing to do is to make sure that after you've found it distally and gotten as far as you want to go distally, to then release it as proximal as you can within your wound before you cut it distally, because once you lose that tension on the nerve, it's a lot harder to get the neurolysis. So I release it proximally. If I haven't cauterized the AIA at that point, I usually do because I'm cursing myself for not doing it earlier. I will cut it distally and then bring it into the ulnar nerve field for the transposition. I usually end up putting a thrombin-soaked gel foam there at the PQ bed in order to get some better hemostasis, and just leaving that in there. And then I'll do my inset, create a perineural window within the AI, or excuse me, within the ulnar motor branch, and then doing the micro.
So that was super detailed and super helpful. Highlights the difference between Chuck and Chris. And talk more about the window. You said a perineural. Are you creating an epineural window, and talk specifically about how you do that, please.
So you've got your motor branch isolated off of your ulnar nerve, which at that point it is still, because you're inside the ulnar nerve, you've already kind of created your epineurial window. So it's total semantics whether it's
True.
epineurial, perineurial, but in your ulnar motor component, there's a little trick that Dr. McKinnon talks about that one of her former fellows kind of innovated, I guess, is that I like to take the marking pen and put it on the ulnar motor component, which I guess at that point is a perineurium, epineurium, whatever you want to say. I like to use, this is a total nerding detail, but there was a study that demonstrated, at least in the ACL tendon harvest, when they're harvesting tendon for an ACL reconstruction, the skin marker that you use to mark the skin is already contaminated. So I will use the black marker, the permanent marker, the Sharpie that has not touched the skin, and put a dot on the window, and then use two jeweler forceps to open up the window. And once I've seen that the black has been pulled off, that's when I'm ready. And it is nice to do it under the microscope and to kind of see the fascicles of the ulnar motor component.
Do you have to do it under a microscope?
I think that's a really good question. I think that you don't have to. I think that our principle, the literature shows that a micro coaptation is better, at least in the digital nerve world, based on cadaveric studies of micro versus loops. I don't think you have to, as long as you're, you know, technically doing it well. There are many people who will do it under loops and then check it under the microscope. I'm not sure how much of that is, it's ease, and then you can bill for the microscope component.
Okay.
But hey, I said it. Said what I said. Uh, but I typically will do it under the scope just because I have it available to me. I don't think you have to, as long as you're doing it well. I think the details of that, coaptation are important. I like to make sure that I'm able to get the ulnar, the AIN to kind of stand up and sit without a lot of tension. And how you place your sutures into configuration can make your life very easy or very hard. If you do the back stitch first, that tends to make it easy to put the front stitches. I usually put 3 stitches, 9 no nylon, spaced 120 degrees apart. And then I make sure after I do that coaptation and I look at it under the scope and I have the trainee or I do it myself, extend the wrist and make sure that there's no tension on that coaptation as the wrist is extended. I still protect the wrist initially for the first 3 weeks, just because I'm OCD. But I like to make sure that that is all set before I do put some glue. That's an off-label use for nerve repair.
Why 3 weeks?
Nobody really knows. I've talked about this with multiple people at multiple places, most recently with Alex Shin at Mayo. We don't know how long it takes for a nerve coaptation to really set up and take, before the microsutures don't need to be there. And it's obviously the sutures stay, but, you know, we think it's 3 weeks. We don't really know. I don't know if anybody's ever going to do that study. David Bergen and I have talked about doing that study, but honestly, it would be a one-off, and I don't think it would lead to much more than that. So if there's any interested young, bright minds that want a cool study to do, please tell us how long it takes a nerve to heal in a human, because everything is based off of animals.
So that's fantastic. I think that's a super helpful summary of your approach to the transfer. I won't belabor that. I do want to get back to the elbow briefly, and then I want to hear your case because
Well,
this is
how do you do your nerve transfer? I'm like dying to know, because I think I just I talked for a very long time, my soliloquy on nerve transfer.
well, no, I enjoyed your soliloquy, and it was a very long time. But I think the principles of what you said are what I follow, but I do it in a less nerve surgeon-y way. And I would say is we divided half of the PQ. We found the arborization of the AIN. We divided the AIN just proximal to that arborization. We did not cauterize the artery. Our inset was pretty similar to what you described. We did it without a microscope. We did it with 3.5 loops. I was operating at our offsite location. While we were doing it, and I've done this before without loops, we did actually discuss looking at this with a microscope. I would love to see how we did. And I think next time I probably will do this under a microscope. Not because I question how well we did, because I think we did well and I liked how it looked. But I agree with you that microscopic approximation, in some ways, it has to be better. But yeah, I was very happy with our transfer.
Man, that sounds great. I will say one technical thing that I have started to do more because others have told me about it, is I've taken sometimes a cob or a key elevator and released some of the FDP muscle off of the ulnar shaft. That kind of sits there because that does help. If you're having a hard time getting your donor nerve to reach without tension, you either can go more proximal on your inset, which is not ideal, but that's what you got to do to avoid tension. But releasing some of that FDP muscle off of the PQ or off of the ulnar shaft with an elevator can certainly help, at least with the actual coaptation. But we know that as soon as you take tension off of everything and close, that everything's going to settle down. But just technically, that has helped me. I'm curious to see how you think about the elbow arthritis component of this whole thing, because I think that makes it more challenging. It's going to have implications for postoperative swelling, how you manage the postoperative course, because it's not just about the nerve at this point, expectations. And then also technically, I don't love putting a nerve right on top of capsule that's been released and addressed in that perspective. So while my go-to usually would be a submuscular transposition, if there's any sort of capsular or elbow joint work, sometimes I just go with a subfascial or subcutaneous transposition.
Agree with everything you said. Before I jump to there, I have to go back because I was smiling when you were describing the arterial branch to the abductor digiti minimi as an important landmark for the motor branch of the ulnar nerve. And that is your worldview. My worldview is that branch is critically important
The Huber.
to maintaining the viability of the muscle if you're going to do a Huber opposition transfer, which I don't do anymore, but I have seen when that surgery goes wrong and you get the muscle basically, but essentially dies if you don't protect that branch. So
If it
super.
makes you feel better, I use it as a landmark and I keep it every time. I don't cauterize it or I don't
Thank
tie
you.
it off. So I
Thank you.
keep it just in case. I thought about a Huber in somebody that I saw recently. I was like, I could do a Huber in this. I was like, nobody does that in adults. Come on.
Well, it's not often long enough in adults, interestingly. That's why. And you have to take it off the pizza board. But that's another podcast. So I think your point about the elbow is really important. And ultimately, in this patient, we did a submuscular, and the patient is just doing really well. It just, the right patient has pain's well controlled. They're going to move. And I worry less about those patients. And the patients that might be a little slow, the concept of putting the nerve down on the bone with an open joint totally worries me. But the right operation for this patient is a submuscular. And so essentially we did that. So tons of osteophyte formation, a number of loose bodies. We worked just from medially. I thought we may have to go laterally too. We did not. And we, really worked hard on the carpentry part of the operation. And the patient was not overly concerned about his motion, but by the same token, I felt like that was one of our goals. So our motion at the end of the surgery was 10 to 135. And I was really happy with that. The nerve actually rested in a good spot, if that makes any sense at all. Usually I just, like you, I think I put it sort of right next to the median nerve. It was a little more medialized. And I was pretty happy with both the results of the elbow debridement and the location of the nerve after the transposition.
I think that's great. And the motion result sounds fantastic. I mean, how much motion do you tell people that they need in terms of a functional arc? I think we talked before, or maybe it was in the podcast or it was on conference, but I, what we think is a functional arc is not always what patients think is a functional arc. So what did you tell them?
Well, two things about that. First is,
Of course, there's two things.
of course, there's two things. I told him that I want to improve his extension, and I would hope to get him. We classically say 30 degrees. I hope to get him, closer to 20 in a final product and up to 130. What I also typically tell patients is, I hope I can improve you 50% in each direction, because I think that's a pretty reasonable goal. Is obtainable, and full motion is not.
Yeah, no, I think that seems like from a patient slash consumer perspective, the 50% goal sounds really reasonable. I try to tell people just with any contracture release type surgery, whether it's elbow, wrist, finger, whatever, that we're not going to make you perfect. Some people, when they bat an eye at that, I kind of back off on surgery, to be honest with you. And I say, well, I think we need to be really aligned on expectations here. Where I think it's harder is patients who get stiff after non-operative treatment, because they feel like, they should be better than they are. That's an aside. For your elbow treatment, did you go into the surgery thinking that you weren't going in to address the actual arthritis, you were going in to address kind of the symptoms of the arthritis. Do you have any future plans for, any other surgery? Is this somebody who may end up with an arthroplasty down the line, or is this just kind of putting the lid on the arthritis?
Yeah, it's a really important question. And the fact that I could go medially with a submuscular, Bob Hotch's over the top approach, really was not what we did. We simply did I lengthened the flexor peroneal mass, and we had a great visualization of the joint. The patient was not complaining about his elbow and his lack of motion and didn't have pain. And so essentially I took off the overgrowth of the coronoid and the olecranon. I took out multiple loose bodies, debrided some bone formation on the anterior humerus and in the olecranon fossa. What I didn't do was a lot of bony contouring of the rest of the humerus because that wasn't his complaint. That's why my motion wasn't perfect. Sure, this patient could end up needing further elbow surgery. I don't think he will. I think he's going to do really, really well, especially from the elbow standpoint and hopefully from the nerve standpoint.
Sounds great. I guess the question is, how much aggressive capsule release did you have to do? Did all the things that you described, meaning the loose body removal, the flexor peroneal lengthening, the limited bony work, did that do it, or did you have to really get into the thick capsule?
Complete capsulectomy anteriorly and posteriorly was sort of just part of the gig because that was the only way to remove the bone that needed to be removed.
Got it. I
Um,
figured.
yeah, and I don't do a lot of big open elbow surgeries anymore, meaning that in a lot of these patients, an arthroscopic approach would be effective. But nerve nerve surgery aside, this was an open approach all the way. I guess the question would have been, if I wasn't addressing his ulnar nerve, how would I have addressed it? Medially, laterally, both. But fortunately, medial approach only was pretty effective. Not perfectly effective, but pretty effective.
So just from a practical perspective, how long did you book this case for? Because this is, I mean, I'm talking about when I'm doing a transposition and doing a nerve transfer, I'm trying to get all tourniquet time in 2 hours. You're much more efficient than I. So how long did you book this case for? And is this the kind of case you put at the end of the day, or how do you logistically schedule this one?
Yeah, so this is booked for 2.5 hours. And I did let the
Two
tourniquet
and a half
down.
hours of wheels in, wheels out time,
Mhm.
or got it?
Two and a half hours, wheels in, wheels out. Patient was blocked. Um, Patient had an indwelling pain catheter. So 3 days of pain relief and allows early motion to start. And I think the surgery was less than 2.5 hours. There's so much nice overlap in those procedures because the hardest part about the elbow debridement is the exposure, which is required for the nerve. And so thankfully, there was synergy there. I put this case at the end of the day, except for some local only cases. It's a big case to do at the end of the day. And in some ways, cases like this may be best done on a different day, not a crazy 2-room day. I think about those things a lot. And I guess in a perfect world, I might. I don't think there was any compromise for the patient doing it when I did it, but it does change the efficiency of the day.
Yeah, no, as I've navigated this process of learning how to use 2 rooms, I've tried to put those longer cases, either on a different day or at the end of the day, because it does make a difference in terms of workflow and efficiency. A 2-room day with 8 medium-sized cases is very different than a 2-room day with 14 to 16 small cases. And unfortunately, my practice is weird, and I've got the combination of the two, as you do as well. So yeah, I think that's a great case. I guess for our therapy colleagues, how did you navigate the therapy part of this afterwards?
So we did, I'm not even sure it's the right approach, but we were assured of hemostasis. There's a little bony bleeding from the elbow, but basically no problems there. So I did splint him for 24 hours before having him start therapy really early while his block was still working. I'm not even sure I had to splint him. Started motion early at 24 hours and did have a resting splint to utilize for protection. And we'll see. He has done quite well to this point.
So no disclosures for this, but did you use the OnQ pain catheter? Is that the indwelling catheter that you used?
Absolutely. Yep.
And how have you found patients managing that? Because that's something that I tried a couple of times. I didn't have a great experience with it. But what's been your experience with that?
I don't use it regularly. I know some of our colleagues use it very regularly. I found it to be effective when I do it. And it's always in cases like this, typically bigger elbow cases where I want early motion or where the patient has, I guess, known pain issues, and even a few patients that have had CRPS where I like that blockade proximally. I feel like it may help us in those challenging patients and honestly, those risky patients where you're operating in a situation where there has been CRPS before.
Now, is the pain catheter placed proximal to your incision, or are you putting it in and having it in your field?
I'm sorry. No, this is anesthesia placed in the supraclavicular area.
Got it. I didn't know if you were putting the bupivacaine directly on the cartilage to kill the rest of the remaining cartilage, or whether you were
No,
whether
no.
you were neurapraxing the nerve proximally with the bupivacaine.
I let the synovial fluid do the damage on the adjacent nerve these days.
Well,
So
that was a great case discussion. I love to see that you're getting into the nerve transfer world. I think that's fantastic.
no competition. These patients are still coming your way. Trust me.
No, that's okay. I will. You can definitely have that because I don't want the arthritis component. I send all that stuff to you. But that's a great case. I think there are a lot of technical points that if listeners do it differently, please educate us because we certainly are not the end all be all on this stuff. And it is always great to hear from people. I think at our next episode, we're going to have a great guest coming up. Is that right?
Yeah, we'll leave it a little bit of a mystery, but we have a guest who hosts her own podcast, which is super interesting. That'll be the next episode, and we actually have a couple of guests planned for the near future.
Okay, well, people fill out the listener survey. After either the next episode or the one after that, we're going to start giving away some stuff. So let's get some feedback on how Chuck and I are doing. We've passed some great milestones, and it's been super fun to do this. It honestly, once we get it on the schedule and get it done, it is one of the highlights of my week.
Well said. Couldn't agree more. Have a wonderful Saturday with the fam and safe travels. But I look forward to talking to you maybe or just seeing your travels on Instagram, one or the other.
I eventually at some point will have to post about hand surgery on Instagram, but it's rather right now about travels and food, and there will be food pictures from this weekend. So,
No doubt. Take care.
all right, take care. Bye.